A very good afternoon, everybody. I am Dr. Komal Chavan, Chairperson, Foxy Medical Disorders in Pregnancy Committee. Welcomes you all for this webinar panel discussion on real-time management of COVID cases. We all know that the whole world is locked down and the whole world has been shaken. There are so many millions have got affected. Thousands have lost their life. And we doctors and our frontline workers are on the forefront, managing, taking care, supporting all these patients with COVID positive infections. So we have with us an eminent panelist who are from the different fields. Some are gynecologists. Apart from that, we have our intensivist, we have our medical experts, and they have the first-hand experience in managing those COVID positive cases. So without making any further delay, I would like to introduce our moderator for today, Dr. Niranjan Chavan. Dr. Niranjan Chavan is a professor and unit chief of LTMGH Science Hospital and having teaching experience of more than 30 years in the busiest medical college in the city of Mumbai. He is also the secretary of Mumbai Obstetrics and Gynec Society, Secretary General of Maharashtra chapter of IAG, chairperson former Foxy Oncology and Trophoblastic Committee, national coordinator of Foxy Medical Disorders in Pregnancy Committee, and also course coordinator of MUHS recognized basic infertility, advanced minimally access surgery, and all the courses and all the academic things he has been doing for all these years. Over to you, Dr. Niranjan Chavan.
Hi guys, welcome to one more session of what the nation wants to hear. And today we have the galaxies of medical intensivists who are the best in India in our program. And we have followed by that the AIMS team who is going to tell us how, why, when they did a section on a COVID positive patients. And I request you all to join us and see the magic of medical intensivist and obstetrician and gynecologist doing wonders for our COVID-19 patients. Today, if you see, we are on the 15th day of the lockdown and it is a really scenario not so good. On the day one, we had 562 cases of active COVID-19 positive and see, we are 5,095 cases today at 9 a.m. We had 63 cases which were cured on the day one of lockdown, and we have only 472 cases which have got cured. 12 deaths occurred on 25th of March, but on 9th of April, there are 166 deaths which have occurred. More than 1100 cases are itself in Maharashtra, and more than 35 cases are no more. I mean, there are no more in this world who are no more, and absolutely it's not a good situation here. But we have those front lines intensivists, and to dedicate to them, I would like to call upon the expert panel. To begin with, Dr. Nirja Batla. Welcome, madam. And you are a professor in obstetric and gynec department of obstetric and gynecology in AIMS, New Delhi. You have donned many hats and you were also a chairperson of the Foxy Gynae Oncology Committee. Right now, you are at the helm of affairs in AIMS because our head of the department, Dr. Sunesh Kumar, is presently quarantined. And madam, you have wonderfully done a superb job by totally supervising and getting all your unit geared up, and people want to hear. We have 800 callers right now who are tuned with us. Thank you, madam. We go to the next speaker now. Wow, Dr. Kanwal Preet Sori. She is from Ludhiana and she has a wonderful CV, but she is also at the front line in Ludhiana and she is an editorial member of the Journal of Anesthesiology. She has areas of expertise as sepsis, nephrocritical care, and resuscitation, infection control, and obviously obstetric critical care. So we are going to give her 5 minutes to talk on that issue. Can I have the next slide, please? Dr. Gunjan Chanchalani. She works in Nanavati Hospital. She has been a protege of Dr. Jindiani, Prakash Jindiani, who is an eminent intensivist, and she has a wonderful experience also in managing COVID-19 cases, and we'll hear from her. She's an executive member of ISCCM. She is author of books for MCQs in critical care medicine and also a recipient of the Presidential Citation Award for the year 2019. She has also been teacher for the critical courses. Welcome, Dr. Gunjan.
Thank you, sir. So just a
Thank you.
correction, I am actually at Bhatia Hospital and not at Nanavati. Thank you.
Oh, thank you, madam, for that correction. And we welcome you. I call upon Dr. Bharat Jagyasi. Dr. Bharat Jagyasi is the head of the critical care department. He is presently working in Reliance Hospital, Kopar Khairane, that is Navi Mumbai. His areas of expertise is DVT, NIV, and sepsis. And he is also presently the joint secretary and the secretary of ISCCM. Welcome, Dr. Bharat Jagyasi. Dr. Ghansham Jagatkar is supposed to join us, but we came to know yesterday he had a COVID-19 patient, so I'm sure he will join us in our show. We will take questions from him later. So now we call the important peoples of AIMS. Now also Dr. Aparna Sharma. She is an additional professor working with Dr. Nirja Batla, and she will also talk today about the protocols and the management when a patient comes in labor and also how to go about in cesarean section. She was also a part of the team of AIMS who have done the cesarean section on the first COVID patient in India, and we will share her experiences also with all of you. She has been a Kamira Orator 2017, has received Foxy Junior Korean Award 2018, and wonderful prizes that she has got. Welcome, madam. I can see Dr. Aparna. Hi.
Hi, sir. Hi, everyone.
Thank you so much. I request to call upon now Dr. Rajesh Kumari. Dr. Rajesh Kumari, are you there?
Yes, sir. Good afternoon, everyone.
Yes, Dr. Rajesh Kumari is our own obstetrician. She is an associate professor and she performed the first cesarean section on the COVID patient. So thank you so much. You have also received awards, and one of them is the best research paper of IUGA, and areas of interest is high risk pregnancy, and presently you are at AIMS. So welcome all of you. Now the forum is open, and I request my panelists, which you will get 5 minutes each to talk on. So let us talk from the intensivist point of view, what the situations they are facing with. So I call upon Dr. Bharat Jagyasi to speak on his field of interest and how he has managed the real time saving these patients of COVID-19. The mic is yours, sir.
Yeah, thank you, sir. Thanks for having me. And unit. So start with initially, we have to be sure that we have to really start with the COVID unit. And when we decided that we have to take care of a staff, healthcare workers, my associate doctors, nurses, and who was working in the ICU and in the hospital. So there were lots of resistance initially especially from the admin area, the billing department and all. So what we did is, we are lucky to be in Reliance Hospital. We have 2 zones. So we build up one more new emergency, and we have totally now 2 different entries. So there is one entry point where we have a flu desk or the screening desk. So everyone who enters the hospital, right from the employee to a patient or the relatives, visitors, they all are screened at the flu desk. So there's a checklist which is available. And once they screen positive, they have to enter through the COVID area. If they screen negative, then they have to enter through the non-COVID area. So there's a COVID area, which is a different emergency. There again, they are screened by the doctor who is already ready in the PP, and there's one nurse always there in the PP. So there they are there in the PP. Once they are positive for the COVID, then they will be screened, admission, and all relatives are being told to wait outside the area. So if there has been a decision of admitting the certain patient, the relatives have to do online they have to fill the form, they have to take a picture of the form on WhatsApp, and it gets transcribed to the billing area where the online payment transcription will happen. So all this has been decided with almost 15 days around. Yes, Dr. Niranjan.
Dr. Bharat, can you please be louder? The nation wants to hear you.
So I'll try to be louder. I've come closer to the mic now. So is it okay?
Yes, thank you so much.
So basically all this started 10 days around. So 10 days prior, when we started with one thing, so every day we would have a meeting of around 2 to 3 hours. So I will come with one plan, then immediately next day myself I'll realize this plan is not working. There's some loophole at this. So this way for 10 days we had a meeting, we had a mock drills, around 10 to 15 mock drills of all these sessions, and we realized we came up with a foolproof plan which was explained to you. This was after 10 to 15 days. It was quite exhausting for us initially to look after the staff, to convincing them, and then again every day we have to change the plans, and we have to change a little in the structure as well. Like we had 4 ICUs, so eventually one ICU we made a totally negative pressure ICU. So one whole ICU has become negative pressure. So with this all lockdown, to have a people working on this to acquire a whatever the technical things or hardware they needed, it was a tough job for everyone to do that. Then the most difficult job what everyone has faced now, I think it's kind of a relax, was getting the PPEs. So you would get the PPEs, but not the real quality PPEs. So what the minimum requirement is, material should be more than 90 GSM thick. It should be impermeable. So initially we had PPEs which are very thin. Those are permeable to the water. So we had one incident when one sister was inside. So she just bent down to pick something. PPE went off. I mean, it totally was torn. Sister came out crying because she thought now the PPE is torn. She's totally exposed to the environment. She's now COVID positive. So we took almost 1 hour to console her, to let her know, okay, no, this doesn't mean that you're positive. It's just the PPE has been torn and you're not exposed to the fomites of the patient. So these were the technical issues what we were facing through to start with our sessions.
What are your biggest concern about rural India right now, which gets less reporting at any time, but especially now?
So rural India, technically, mentally, they are safe because as you said, we have no reporting as such. So anyone who is staying in a metro, they are in fact moving towards a rural area considering that there's no infection. But as rightly told by you, there's no testing happening in the rural India. So concern is it might be true there's no infection, because we have to agree to this, all of us. It's been an imported infection. Whatever has come from the... Yes, sir.
Dr. Bhatla, madam, what do you would like to comment on this? The nation wants to know the concern about rural India right now.
Yes, Dr. Niranjan, I think this is an excellent report by Dr. Bharat. I think they have done a fantastic job by the way he is describing it. And I think we can sort of empathize and understand that, because we had a pretty much similar journey as we set out, knowing that our obstetrics concern is always there, and any moment any of our patients may come, even whatever was being said that we are in stage 2 and all, but you never know which patient has a contact with whom and when she comes. And we started exactly the same process of going through the literature, going through the guidelines, making our SOPs, getting everyone on the same page was not always easy, and identifying the space, because none of our hospitals have ever been made with this idea of ID and this flow that is required, that the patient goes from one entrance, the donning is happening in another area, getting out, the doffing, so many criteria, having shower spaces for doctors before they get out. No hospital thinks about these things because they're always maximizing patient care space. So anyway, we were able to do that with a very effective team. We had Dr. Aparna is leading our maternal fetal medicine side.
Yes.
Dr. Ramesh, our neonatologist, our anesthesiologist, the microbiologist, to see and approve that this is all right from their perspective. So many people, hospital administration, everybody. And then the dry runs, as he described, the mock drills. And we were ready on the 28th that we may or may not get. And we had made our rosters with the teams. We had divided everyone in 3 teams so that one team is off for 2 weeks and we don't contaminate, and everyone have to go for isolation if anything happens. So with that, we had the next week when Dr. Rajesh Kumari was our COVID consultant, as we called it, and lo and behold, most unexpectedly, we got the patient who was one of our own staff members' wife who had got exposed somewhere. Luckily, she was an asymptomatic patient, so that was good for her and good for her baby. But yes, our concern is very much out there that we don't know. I don't know about the rural India because still many districts are free. And so we are not, it's not all of them are equally exposed. But in our cities where we are based, our slum areas, our urban slums, these are more of a problem really than even our rural areas at this time.
So to summarize, I think we are having less reporting, but we can't say about that. Still, we have to do a lot of work on that. There are poor who are dying of respiratory diseases. Maybe they are not recorded. It won't show up in any sort of death statistics. Maybe only 1/5 of them are being reported. I would like to now go to Dr. Kanwal Preet Sodhi. Madam, we would like to hear the experience from Ludhiana. I came to know that you have many number of COVID-19 cases in your hospital and there are a lot of issues. The nation wants to hear from you and there are now more than 900 members who have joined. I would like to say all of you are wonderful panelists. Please go ahead.
Good afternoon all. Actually, I'm heading a critical care unit in one of the level 2 hospitals. And this was basically an obstetric and a pediatric hospital which has been converted into a 200-bedded multi-specialty unit. And since I am dealing with the COVID positive COVID suspect patients, exactly I did not have any of the COVID positive patient as of now. So I'll be more stressing upon like how we started with the this COVID positive unit at our hospital, which was a big challenge. Actually, I think the Indian government's public health efforts, they are a big boost preventing the true spread of COVID. Like countries like Taiwan and South Korea, they're examples which provide encouragement that a well executed public health plan, it can minimize the potential for operational cases. But if we look at the scenario in the Western world, what is happening in US and Italy, so these are one of the best healthcare facilities in the world. So it can just be a matter of weeks before many of our hospitals in the country, they do run out of space. So this is the right time to build field hospitals and to rather repurpose the smaller units into quarantine centers and what all. So basically a workup plan for the timely execution is what is required. And this includes the protocols to triage the patients, like as Dr. Bharat very nicely elaborated what they are done in the hospital. And then building up the COVID specific units, including like if we want to convert, as Madam has said, that there were, Dr. Bharat also said that there were 4 units and they converted one of them into the COVID. As we have also done, we have basically converted our step-down unit into a COVID unit exclusively. So the resource and manpower allocations was another issue, and backup plans should the intensive care beds run out, like they are overrunning. So when we converted the step-down unit into a corona unit, it's not a negative pressure, but it has its own exhaust, a separate AC duct, and the whole area has been cordoned off. Basically, the patient as well as the visitors, if at all, at one point of only one visit, we allow that too as a video call in our counseling room. So this area has been cordoned off, and the biggest hitch, as everybody is, it is expected also that the mindset of the junior doctors and the staff to pitch in for the COVID unit, both mentally, emotionally, they had to be charged up and geared up, be prepared for working in a COVID unit. So here's where our role as a team leader, it comes into play. And there was a huge support from our managing director. He's a pediatrician himself, and the hospital administration as a whole. But main issue again, when we started with the COVID unit, was the availability of the PPs, which within few days it went into a scarcity. So thereby, what help came was from the admin people, the deputy commissioner and the whole admin of the Ludhiana district. It came into Ludhiana being a hosiery hub. So they engaged the local Ludhiana hosiery people into the sort of making up these PPs. And after many checks, standard checks. Now we have procured the PPs and now they are ready to even outsource to the other cities. So this is a big thing, and this actually took up 10 days, wherein we had to refuse many COVID suspect patients and we had to refer to other centers. But now for the last 7 days, we have ample of PPs available at our place and all through the Ludhiana and Punjab. But most important, I think, as intensivists, as the gynecologists and the obstetricians working here and everybody in the healthcare, is like we need to reserve this resource, the appropriate use of resource. This is very important at this point of time. Like if we are expecting this to continue for a long time, as the world is overall expecting that this is not going to just stop in a few days. So we need to restrict our resources. We have to appropriately use, and not only the PPs, the testing kits, which we know are very limited in our country. So we should be very clear about, like, yes, sir?
Yeah, madam, would you like to share something regarding non-invasive ventilation for COVID patients, and which patients should be hospitalized, which patients require intensive care? Can you talk something about critical care, which is your forte? Any specific ventilation strategies?
Sure, sir. Firstly, we should know like which all patients to hospitalize and which actually need the intensive care. So, as the WHO is also divided into mild, moderate, and severe cases, and more than around 81% of patients are the milder patients. There are patients who have only mild clinical signs, symptoms with actually no pneumonia on clinical imaging. And the moderate patients are those with signs and symptoms and the clinical features of the typical on imaging the pneumonia is there. And they are the ones who need to be hospitalized and observed further. And the patients who go into the intensive care units, they are actually who have the severe symptoms. Like patients are tachypneic with a respiratory rate of more than 30. They are desaturating, and on room air, they have the saturations of less than 93, and some guidelines say 94%, and the PaO2 FiO2 ratio of less than 300. And beyond that, if the patients have more than 50% increase in the involved lung area compared with the previous lung imaging, which is available in previous 24 to 48 hours, it is more than 50% increase in the involved lung area. They are the patients who actually need intensive care. Leading besides, we all know the respiratory failure requiring mechanical ventilation, patients who are in shock and in multi-organ failure, they obviously are the patients who need entry into the intensive care unit. But yes, if you talk about the non-invasive ventilation, as of now, none of the guidelines, they actually recommend using non-invasive ventilation or even high flow nasal oxygenation for COVID positive patients. The reason being basically they are thought to be aerosol generating things. They have a potential for aerosol generation, but still because of the limited number of ventilators we have in our country, I'll not say not only my center, across India we have very limited number of ventilators. So MLV can be utilized. Yes.
Madam, we have seen many videos where one ventilator, they have attached those Y-shaped tubes and 8 patients have been there. Is such a situation going to come in India? Because we have been seeing in Italy, in US, in Spain, in France, there are patients who are in corridors. Do all patients require ventilators? And if they require ventilators, do such a situation will come to India maybe after 1 month? What do you, can you...
I pray such a situation doesn't arise, because this is actually not a scientific thing. To ventilate with one ventilator, we are ventilating multiple patients. So every patient has a different physiology. The lung pathology and the physiology is different. So giving the same PEEP, same time volume, the compliance of each and every lung is different. So we cannot just ventilate multiple patients with one ventilator. This is scientifically not correct, and many papers we should not ventilate. This is seems to be an innovative idea for people who are sitting on the other side, that yes, you can optimize the resource, but it is not a scientific thing to do. So we will not recommend, and as such the ISCCM also does not recommend that ventilating multiple patients with the same ventilation.
Okay, thank you. Thank you, Dr. Kamalpreet Sodhi. We will get back to you. You have given justice to the question. Now I call upon Dr. Gunjan. Dr. Gunjan, hi. Would you like to say what is happening at Bhatia Hospital and in Mumbai? Will you please unmute your mic? There is a red symbol. Thank
Sorry.
you.
Yeah. Thank you so much for having me here, sir. First thing I want to say is pandemics have been known since the 18th century. This is not the first time we are having it. The main problem that we have with this pandemic is its contagiousness and its longevity, or whatever the uncertainty of the period of infectivity of the virus that we have. We do not know how long the virus is infective. And the other problem that we are having is with the testing. The testing gives us a lot of false negative report. Like you must have read in the Mumbai newspapers this morning that Bhatia hospital is shut. In fact, most of the South Mumbai hospitals have been shut down because of the spread of the infection amongst the patients and amongst the healthcare workers.
So, madam, if you have a small practice in a clinic, and we are talking about general practitioners, if they get patients of fever with cough,
so that is what I'm
so
trying to tell
where
you.
do we go? If Bhatia is closed, if Jaslok is closed, if Bridge Candy is closed, then where will they go?
So unfortunately, they will have to come to the suburban, or maybe HN is one option that they have. But what I would rather say, what I have learned from my experience as Bhatia is, despite all efforts that we took at triaging, of segregating, of having codes to be called out when a patient comes, who was a suspected case with the symptoms that have been described till date, we failed in a way because patients of pancreatitis or patients who had a COVID negative report came out to be positive after 4 days. So despite after all the things, I think there is only one conclusion, that every patient is positive till the patient is symptom free. We should consider each and every patient to be positive.
Okay, so what is your real-time experience now happening in Mumbai, and what do you see the scenario in future? Will there be many cases which will be now requiring any ventilatory support, or will they be have to be just managed in the situations of fever, cough, and cold, and will all they are more worried? People want to know about it.
So definitely, sir. I think definitely in Mumbai there will be a lot of cases, especially because of the overcrowding that we have. The only thing that saves from this virus is social distancing and hand hygiene. And unfortunately, amongst a lot of people in Mumbai, we can't afford this kind of level of distancing as well as hygiene that we are expecting. So that the primary prevention is the only thing that we can do. And containing is the best that the government can do at this moment.
Okay, containment. While coming from my Science Hospital today, I saw that Dharavi has been sealed. The 60 feet road has been sealed. There were 3 to 4 nakabandis everywhere. They have become very strict since yesterday, and there are masks to be put. If they find anyone without mask, they are, putting some FIRs on them. Also, they are checking the vehicle. So it is really a grueling task for the police force. And even they check my car, that where I am going, and the logo, etc. So I think people should understand that it is a very serious matter, and it is situations are going haywire. But I think Dr. Nirja Batla, what is the situation in Delhi? Can you just say something about it?
The situation has escalated a lot, and there are a lot more cases being reported now. A lot more new cases have come forward. Of course, when we look from the obstetricians' perspective, still we have not found that many. But then, as you said, every patient is not being tested, and our risk of exposure of our people is very high, because there is a lot of splash and contamination possibility. So we are now trying to, of course, there are 2 hospitals right now which have been designated as COVID hospitals. One is our trauma center, and one now the Lok Nayak Jayaprakash, which is attached with Maulana Azad MAMC, is also being designated. As well as we have one at Jhajjar, which was our National Cancer Institute, is being used to house a lot of the COVID positive patients. And of course, there are many other government hospitals which are continuing to house them, as well as private hospitals as well have been charged with taking care of the COVID patients as well. So now with that, and with a lot more laboratories opening up for testing, it seems that we may have a better opportunity, and we are now talking about screening all positive patients, all suspect patients who are coming in, even from our obstetric perspective, even from surgical perspective, that they should be screened. But as was already pointed out, they could be positive today and become positive in the negative today and positive in the next test 4 days down the line. So a universal precaution type of scenario has to now unfold.
Okay. Dr. Kanwal Preet, is there any role of prophylactic HCQ in healthcare workers, and who should take?
Sir, actually, the guidelines by ICMR have been given, and even the ISCCM has supposedly said that yes, the healthcare workers who have been in direct contact, actually the healthcare workers as such, and persons who have been in direct contact with the HCQ, this COVID positive patients, they should be the ones who should be taking HCQs in a dose of 400 milligram BD on day 1 and followed by 400 OD for once a week for 7 weeks. So this is what has been recommended. But how much, because many countries do not approve of this, and this is a questionable thing. But in India, it is being used as a prophylactic drug.
Would you recommend? Oh, sorry. Please continue.
No, I just completed. Yes, sir.
Okay. Is it recommended? What is
Yes,
the
sir.
dose? What is the dose which you recommend?
So 400 milligram BD on day 1 and followed by 400 milligram once a week for 7 weeks.
Since you are coming in contact with COVID-19 patients and their relatives, do we recommend our general practitioners or physicians who are coming in contact that they should also give HCQs to their family members, or
No,
only?
sir. As of now, we are not giving. Like I have taken, but my son and my husband, who is not into a COVID hospital, so we as only I had the HCQ prophylaxis, and this is what we have recommended for other people also.
So the recommendation is that for HCQ prophylaxis, healthcare workers who are treating these patients should take prophylaxis for 8 weeks at least. 7 to 8 weeks is what is written. And family who have a positive patient and they have been living with that patient, exposed to him prior, we can give them this prophylaxis for a duration of 3 weeks, which is a weekly dose, not a daily dose. That is what the ICMR recommends. But then now, whatever papers were published for the ICMR to take this decision have now been, you could say, withdrawn or whatever, questioned. So we do not know whether it really works or not, but that is the only option we have probably.
Okay, Dr. Bharat, are you there?
Yes, I'm very much there. Yeah.
Yeah, thank you. What all investigations we do, or how can we prognosticate them for a COVID-19 patient, whether he is improving or whether he is deteriorating or whether he will require any ventilatory support? Do we have to do every second, third day some investigations to monitor his parameters?
So we have the prognosticate markers, and this is what we do for our patients as well. So on admission, what we do is initially, along with the CBC, RFT, LFT, there are certain prognosticate markers like CRP is one, LDH is one more, then CPK-MB, or you do TROPI and D-dimer. So also the pathophysiology, what is coming in the management of COVID patient is, it's basically more of a hypercoagulable state. So ARDS also, what is seen is not an actual ARDS. They say these are multiple pulmonary microthrombi. And why this is coming? Because in the ARDS, the lung is very compliant. It's very difficult to ventilate the patient. But in this situation, in ARDS, lung is not compliant. It's very difficult. But in this situation, lung is pretty much compliant and it's kind of easy to ventilate, but still the hypoxia doesn't improve. So it's a hypercoagulable state, and that is why we have a D-dimer in one of the prognosticate markers, and also there were reports of stroke coming in MI in the COVID patients. So these are the prognosticate markers. So if the CPK-MB is more than double, LDH is more than 500, D-dimer is more than 8, troponins are more than 1 or 2, and CRP has a linear relation with the patient. So supposedly I had one patient who was not kind of intubated but very close. In that patient, CRP was very linear. I mean, the moment patient was saying he's not better, CRP was going up, and the day he said he's feeling good, CRP actually went down. And CPK also kind of correlated with his generalized condition. So we started this of doing all these prognostic markers alternate day with every patient along with the routine investigation. And also the lymphopenia is seen in all these cases. So lymphopenia is one of the marker where you can say whether patient is improving or not. So in the initial phase, there's a lymphopenia. So what we do is neutrophil to lymphocyte ratio. And also there's a paper coming from the Wuhan, and also the Medanta has published a paper where they say when the absolute neutrophil counts in ratio with the absolute lymphocyte counts are more than 1.7 or more than 2, if you take as a figure, then the patient's it's not a good sign and patient wouldn't do well.
Thank you. So I think we have given justice to the medical aspect, and now we move on to there's one more question to the medical intensivist before I go on to the obstetric and gynec. What is the role of ACE blockers in COVID-19 for hypertension in COVID patients? Any one of you, please.
I'll take this. All right. Kaval, want to take it?
No, you continue. Not anything.
All right. So basically, role of ACE inhibitors. How the hypothesis was generated, sir. Initially, the Italy had a lots of mortality. So initially, the hypothesis was maybe the age is a factor. Then they realized the majority of the patient took ibuprofen before coming to the hospital, and they were on the ACE inhibitors because of being hypertensive. So they thought maybe something related to the ibuprofen and ACE inhibitors. And also there have been many papers before this pandemic of ACE inhibitors on the ARDS. So there's a receptor which also helps in the multiplication of the virus, but also at the same time, ACE inhibitors are known to be protective in the ARDS as those are anti-inflammatory. So as of now, initially the Lancet came up with the paper saying there should be a caution against the ibuprofen and ACE inhibitors. Then the NEGM came up and they said there's no need of stopping it. Then Society of Cardiology said there's no need of stopping it. So looking at all these debatable views, if you ask me, personal opinion would be not to stop ACE inhibitor as of now. But if someone is suffering from the COVID and proven COVID and we have an option, we should switch to it. But there's no definite scientific evidence to support this thing. But since it's not going to harm it and you have many more options available, I would suggest if there's a proven COVID patient, we should be stopping ACE inhibitor and then switch to the calcium channel blockers, but not for everyone.
Okay, thank you. Now we go to Rajesh Kumari. Can we have Dr. Rajesh Kumari here? Dr.
Yes,
Rajesh Kumari, you are the first doctor in the team of Dr. Nirja Bhatla madam who has performed the LSCS, and everybody wants to know how would you go about in a patient who you take for cesarean sections and what are the things which you will see. After Rajesh Kumari, we will go to Dr. Aparna and we will take questions from her regarding the protocol management when a patient is not in labor. But first is Dr. Rajesh Kumari.
Good afternoon, everyone. So, whenever we are dealing with COVID-19 positive patient and pregnancy, so treatment or clinical management of these patients should be initiated at the point of entry of these patients in the hospital or in the ward. Like they have to prior inform us or treating physician that they are coming or they are in labor with symptoms. So like hand hygiene or PPE should be provided to the physician or daily consultant. Next point is we have to rule out symptomatic patient or asymptomatic patient. If patient is asymptomatic, there is no symptom, but she is COVID positive patient, she should be hospitalized right now. This is our guideline. And in isolation area. And we have to counsel regarding her pregnancy, regarding continuation of pregnancy or termination of pregnancy, etc. We have to discuss these with the patient and we should continue her iron, calcium, etc. at that time. But if patient is symptomatic and her condition is worsening, then we should discuss this with the relative of the patient, and we should discuss with with our anesthetist, neonatologist, and we should make a team for this. This is not a single person job. As under Professor Neerja Batla, we made a team with obstetrician, neonatologist, anesthetist, and hospital administration also. So we, after making a team, and we are planning to deliver the normal delivery, or we are going to do the cesarean section. These both are different. If patient is not asymptomatic or not in a severe condition, then we can go for normal delivery, and she is near term. But if there is any obstetric indication or patient is deteriorating, and we want to if treating physician is said she can survive if we can deliver the baby as soon as possible, then we can go for cesarean section. Now, if we are going for cesarean section, we want a separate OT for COVID patient. So we want a donning area and doffing area proper, and we want a separate corridor for these patients, as we have done in our hospital. So proper donning is required for this patient. And during cesarean section, before we are making a team, anesthetist and operative surgeon and sisters, they should, before doing the cesarean section or before going for the delivery, make a team and make a mock drill. And because there is lot of difficulty during when we are wearing this PPEs and mask and goggles and shield, there is lot of hearing problem also. So we can use sign languages also. That will be good for everyone. Yeah, we are doing this, we want this, everything. We want suture, we want scissor, etc. That will be good for us. And we have to, before doing any delivery and before doing cesarean section, we have to keep our PPH kit ready. That's because we don't know when will be we need these kits. So we have to do as a teamwork. And after delivery of baby, right now there is no criteria कि delayed cord clamping or early cord clamping. So we can, if baby is not any deterioration and baby is quite okay, then we can do delayed cord clamping. And if mother is in good condition, then we can allow her to breastfeed also, after proper mask and proper hand washing before and after touching the baby.
Okay, thank you. Dr. Aparna?
Yes.
Are you there? Yes,
Yes,
madam.
yes, I'm
now, I request you to speak for 5 minutes regarding your protocols about patient in labor and for normal delivery, and your thought about the section which you went. Basically, the whole program is on real-time experience which we have gone through, and wonderfully all of you have explained the medical intensivist. So the nation wants to know about from you.
Yes. So, sir, I would like to talk about two things here, like how we actually went about preparing for the whole thing, and like Dr. Neerja Batla gave you an overview of the whole thing, but a little bit in detail. And the second part is like a basic overview of how we should go about a patient deliver a patient who's COVID positive. So I would say that any obstetric unit, whether a small unit, a nursing home, or whether a big hospital, should just have 5 principles. When we discussed the whole thing, we thought we can just sum it up into 5 points. So the first is SOP. S. The first is have an SOP. Every body today, RCOG, ACOG, WHO will give you guidelines, but make your own SOP. So first thing is, as a department, we made our own SOP. Where will the patient entry be? Where is your place for isolation? Where will the patient go out from? So the first point is S, which is an SOP. The second point is infrastructure. Do you have a place for screening? So we made a place, put one table outside our labor room where the patient, before she enters the labor room, she will be screened with a history and a simple temperature or a thermometer or simple history of contact. Then have a place for isolation. You will not need a whole building, but at least have a place for isolating that woman. So the second is infrastructure. So the first point is SOP, second is infrastructure. The third is personnel. How well you are training your people. You train your people in SOP, and the second is train your people for wearing the personal protective equipment. And for this, as a team, we trained each of our faculty, residents, cleaner, and nursing staff, and even the OT technicians. And the most interesting part was that during the cesarean section, there was one person who was not trained in wearing the PPE, and he was the one who was running about. And we called him back that please don't go into that area. So interestingly, we have to train each and every person in wearing the personal protective equipment, and we have to make a training arrangement for that. So SIP, and the fourth P is procure the personal protective equipment. And it is not just procurement. The part is rationalizing the use. And WHO has given that don't give a person in the screening area an ICU level PPE. A person in the screening area can wear a mask and sit. So save your PPE. Procure your PPE, but more importantly, guard your PPE. Give the correct PPE to the correct person. So organization of your area is very important. And the fifth part is infection control practices. What is there is train your nurses on waste disposal. The doffing area should have 3 bins. You can reuse your goggles. Where will you dispose of your clothes, your PPs? How will you dispose of your PPs? After the cesarean section, one of the consultants actually waited till 10 o'clock in the night to get the correct waste disposal done. That is the importance of training in infection control practices. Each of these parts, so 5 aspects of preparing your unit, whether it's the biggest hospital in the world or you have a nursing home. Make your own SOP, get your infrastructure in place. You don't need a building. You just need to reorganize your place. Train your personnel, get your PPE in place, which you should be rationing for the correct time, and get your PPE. And the 5th point is get the correct infection control practices in place. If you have these 5 principles in place, your COVID unit will be ready for correct use. Now, the second part of the thing is, ma'am, would you like to add something?
No, I think that's very, very well spoken, Aparna. I wanted to say that the FOXI guidelines are really excellent. They've been drafted very, very well, and we found them very useful and helpful as we went along. And I want to say also that you have to be very careful about the personnel when you're dealing with obstetrics. You have to be very careful about the personnel you select to go in, because as we know that you have to take the matter of life and death decisions very quickly. Everything happens very fast. So you have to have a team that you are confident that that person can take the right decisions and do all the right skills, because it will take time for the next person to go in if you call for help. Because donning the PPE and getting in there is not a matter of a few seconds. It's like reasonable length. So be careful whom you appoint in your team, so that the chance that they will require help is minimal. But we have the standby person ready in the scrubs, at least, ready to don the PPE and go in. As you said, it's about rationalizing the minimum number in the right PPE.
Yeah, so I would like to add a few more things, that in the personal part, that when you are actually training in PPE, the training has to be in the mock drills also. And also in the personal part, I would just like to add an interesting anecdote, that before the surgery, the nurses refused to go in, saying that what will happen after the surgery? Okay, I am wearing the PPE, but after that, I don't want to go home because I am operated on a COVID positive patient. So now after that, so we and other team members, we counseled them, we showed them the CDC document, which says that if you actually go in on a COVID positive patient with a fully donned PPE, you do not need a quarantine, you are perfectly safe. So this message has to go to all the healthcare providers across the country, that you are the safest if you are in PPE. It is the inadvertent exposure which puts you at risk.
And here is the importance of being prepared, not being thrown into it without providers.
That we understand that we need to motivate our team members that we are doing a great job and they have to be at it. And if we if we wear the PPEs, we are not putting our lives at risk too much. Like, of course, it's a risk, but we should be careful at all times. So I think this was a very, and right now, just a few minutes back, I got a call from the HOD microbiology, who was also a part of our team, asking, how are your nursing sisters doing? How did they agree to actually go into the surgery? And we said that it's all about motivation and giving them the right evidence. So I think all these anecdotes are really useful for the other team members to keep them motivated to go ahead and keep working for the next cases that are always going to come. And these questions are always going to happen. Yes, ma'am.
One more point I wanted to say was that we do have a protocol that whoever has gone in PPE and been in there for 6 hours in the PPE, we are giving them 2 days off, not because we are isolating them or quarantining them, but it's because it is such a stiff duty that we're giving them time, at least now, while we have the manpower to do it.
Okay, can I ask a question? This is by Dr. Vandana Shetty.
Yes, so beyond that, I think
is
this was
asking
about
how
the
frequently to
preparation.
sanitize.
After the surgery also, we are still streamlining our procedures, and every day is a new challenge as we go on. The suspect area and the COVID positive area still needs further streamlining, and as the cases come in, we are going to further streamline our processes in place. As far as the labor protocol and the labor management is concerned, we had a webinar in the morning, and just to tell us a few gross points, any COVID positive patients can undergo normal labor. Normal planned induction is not contraindicated. Within the labor process, what we need to understand is that we can allow birth companion. However, standard procedure of screening should be done, and only if she's asymptomatic, she should be allowed. Person-to-person contact should be kept at a minimum. The labor monitoring is a standard procedure. However, even ARM can be allowed. And ma'am, let me finish the process of normal labor, and then we can have the questions. So for the process of labor monitoring remains as we do it normally. However, prolonged or labor should be avoided. The labor analgesia is not contraindicated. As far as anesthesia is concerned, regional anesthesia is preferred. General anesthesia is considered to be an aerosol generating procedure, and hence it should be avoided. Entonox for pain relief should be avoided as per some of the guidelines of for anesthesia. Then, as far as whether we should be testing every person, guidelines are still evolving. So I would not say or give a recommendation at the present time. As far as HCQ for prophylaxis is concerned, I would say we still have a guarded prognosis for everybody. So for prophylaxis, as we discussed, healthcare providers in direct contact, we might recommend, but not for everybody. So I think for labor, we just did a webinar, and these are the take-home points. But most importantly, respectful maternity care would still be the most important thing, even in times of a pandemic. Yes, sir.
Dr. Kavalpreet Sodhi, please.
Yes.
Sir, actually, very nicely elaborated how they went about it. But in my experience, like all the literature I've been going through, I think a planned neonatal team attendance is also a must. Because in the case series of around 18 pregnant patients, 19 days delivered, one of them was twins, 8 of them had fetal compromise. So I think the plan is that we could waste the time in donning and doffing of the PPE.
I must say that our neonatal team is the pillar of our strength, and they were like with us through everything. So I must say that Dr. Ramesh is is a part of our team rather than a neonatal team. So I must put that on record.
Congratulations.
Thank you. Thank you.
They were all the time, they were with us.
Yeah, thank you. Dr. Praneeth Patil is asking a question. Dr. Gunjan, you can take this. How to manage ER intubation calls and code blue in suspected proven case with respect to precautions and resource management? Kindly unmute. Please.
Yeah, I did unmute. Intubation is a very high aerosol generating procedure. So everybody, the person who's intubating specifically has to take utmost care while he's intubating, and it is recommended that we use video laryngoscopes rather than the regular laryngoscopes, because that increases the distance between the patient and the operator. Even the ones who are surrounding the patient, who are like a drug nurse or anybody, we can decrease the personnel to 2 or 3, and all of them should wear PPEs during this process, and preferably it should be done in a negative pressure room and not in a regular room. And the most important part is preparing. Prepare well, anticipate a difficult intubation, and keep everything ready in hand so that there is no chaos. It has to be a rapid sequence intubation, and there should be no ventilation with AMBU. So, yes, sir?
Please continue. Yeah.
So there should be no ventilation with AMBU. Like even when you are ventilating with a mask, it is just pre-oxygenation, give the drugs and intubate, and the best or the operator who's the most experienced should be taking this role so that there are no failures or no desaturations during this episode. Even after the tube is passed, the confirmation with auscultation is difficult because most of us are wearing PPE. So using chest expansion and EtCO2 as the modality of confirmation is the best. Again, after putting the tube inside, after inflating the cuff, you have to connect directly to the ventilator rather than AMBUing again, because ventilation is kind of, with the AMBU is kind of a high aerosol generating thing. And so it has to be directly connected to a ventilator. I mean, others can, Dr. Kaval and Dr. Bharat can add if I have missed any point for intubation. Aerosol boxes are what have come up now, but I don't know how easy they are because they just allow the hands to go inside. So it may probably make the process more difficult rather than easy for us.
Actually, Dr. Gunjan very nicely explained the Safe Airway Society. That is, they have given a consensus guidelines. That is an Australian guideline and very nice document to really to read upon. And to add upon what Dr. Gunjan said, just we have to pre-oxygenate nicely without positive pressure. And using two-hand grip, especially when we are managing the airway. When we are holding onto the mask, it has to be a two-hand grip. And what is important is we have to prevent any cuffing. It has to be a deep sedation, and rapid sequence induction is certainly what is required. Dr. Bharat?
No, you guys have said everything right. I mean, there's nothing to add on. Basically, to prevent the aerolization and to have the very smoothness of the procedure. So avoid AMBUing and use the relaxants just to smoothen it. That's it.
Yeah, there is one more question from Dr. A. Zaman. Is there a choice of vaginal versus cesarean delivery in a case of corona-infected mother? So do we do directly a cesarean section, or we should do a normal vaginal delivery first?
You know, we debated this a lot, and we came to the conclusion that we should not go for a direct cesarean just because of this thing. In our case, for example, this patient had an oblique lie, though she had a previous normal delivery. But also we have to see if it's going to be a very protracted labor. There is also an issue of how many PPEs are going to get used for that delivery, because you cannot expect any doctor for more than 6 hours, neither the nurse. If there are a lot of patients simultaneously there, then it probably makes it more cost effective to do so. If there is just the one, then that issue is there. And from the literature, the majority of patients ended up with cesarean because there was fetal distress, almost like 47 out of 49, that type of numbers. So we have to take each case on an individual basis. Certainly if the patient is in spontaneous labor, it makes the decision very easy. But if it is a patient who needs induction, then we have to see what is the bishop looking like, what is really realistically the outcome going to be. And if it's a multi and you expect a good outcome, definitely. If it's a primary, you weigh the balance. I think it has to be individualized.
Yeah. So basically, it is only if the cesarean section to be done, only there is an obstetric indication and not as a routine. But there are so many patients who are coming near term. So do we induce or deliver such patients, or do we wait for the infection to subside? They say that some says are in a thought that second week is better than the third. Third is more infective. So what is your take on that? Anybody?
So this is one question, is that, you know, if they have come, especially if they have come asymptomatic, and then we find that we can deliver them before they develop any chest symptoms or anything, then that is actually they are in a better place, and chances of fetal outcome being good are also.
They're not in labor that time.
Yeah, they are not in labor, but the risk that they might develop symptoms, that their own condition might become more critical. So that is to be weighed again and to be seen.
Okay. So there is one question. Generally, now there is a question that generally the audience, like who are our general practitioners and everybody, are very keen to know. So how do they manage simple steps what they can do at their clinic when they have some patient, maybe a suspect or whatever, they can universally follow. Anybody can just sum it up like point wise so that they can note down it. Yeah, Dr. Bharat also can take it.
Question is for GP, you said, right?
Yes, it's for general practitioners.
General practitioner, I would say they are at risk quite a bit. And as Dr. Aparna was talking about all this, so one point what she said is, when you're working in a COVID area, you're really safe. There's nothing to be worried about when you know the patient is COVID and you have all the protections around. Absolutely nothing is going to happen to you. The problem is when you work in a non-COVID area. This is where the problem starts. And that is what the problem with the GP is, because a number of patients they come across, they see is, and you never know who is the COVID one. So what I would say is they have to rework on it and take every patient as a COVID. So usually whenever the GP practices, you see the next stool lying to them is very close to the patient. So they can have an arrangement in a cabin. You look for a spacious cabin where they are sitting little far away from the patient, maybe a 1 meter far away from the patient. And you examine and touch a patient only when it's necessary. Otherwise, it's been a routine GP practice of putting the stetho around, looking at the pulse rate of the patient. So all those practices have to do away with things. Now, this is a new era. You have to come up with a non-touch technique where you maintain a distance, ask for the symptoms, and avoid examining as far as is possible. And obviously, then they have to, mask needs to be there and hand washing has to be practiced. And also you have to make a habit of not touching your face, eyes, nose, mouth very frequently, because ultimately the virus passes either through your mouth, nose or eyes. So you have to make a habit, even if your hands are infected, if you're not touching it and you're maintaining a good social distancing of around a meter or so, it should be fine with that.
Yes. So very important points for them. One more thing is, do they have to examine all the patients who come with proper symptom, or they can directly refer to the COVID center?
No, I would suggest against examination. If the suspicion is very high and you feel it's a COVID patient, straight away that patient goes out of OPD as soon as possible.
Yes. So there is one more question from Dr. Prashant Shinde, where they have asked for results of convalescent plasma in Indian scenario. There are any studies upon, I can't get his question actually, but they have said what are the results of using plasma in the Indian.
This might come up. This was tried in some places, but still it's not come up strongly, because what has been suggested, whenever the patient is in convalescent phase or recovering, there's a good antibodies available in the plasma. So those kind of antibodies could be used as a treatment. But again, I'm not very confident on commenting anything on it, but I'm not a big fan of it, because wherever it's been tried, it's failed. If Gunjan and Kaval has to add on to it, I'll be happy to hear.
Yes. Yeah, so Gunjan, you can add on it.
I think the studies which have come from Italy are quite in favor of giving convalescent plasma. So that is the only therapy, in fact, which is available right now, which they say is effective to a certain extent. So what they do is, a person or a patient who has recovered from COVID, if he has remained symptom-free from after 14 days, he can voluntarily come and donate his plasma. Around 400 ml is what was mentioned is collected, and then it is given to patients who are critically ill. And this is more of a trial basis that they are doing, and they have found decently well results in this. In India, unfortunately, we have no data as of now, but I think in Karnataka, they are starting a study with the help of ICMR for this plasma to be used.
Okay. And you, Dr. Kavalpreet, you want to add something?
Actually, as for the convalescent plasma, I think US FDA has given a clear-cut guidance, like how to use and from where to procure and how to go by the legal issues. But I think none of the centers as of now in India, they're using the convalescent plasma. And main issue will be the logistics. I think India, actually, the testing itself is so low, and how many people will be ready and enthusiastic to donate, I can't say, but the logistic issues certainly will be there in the Indian scenario. So what Dr. Gunjan was saying, that a trial is about to start at Karnataka. That is a new thing for me. Well, it's good.
Yes, we hope new studies come and we know our way out. But definitely now we are treating so many patients and there is little controversy about discharge. So if you have admitted a patient, when is the ideal time the patient is discharged, and after discharge, is the patient infective, and what are the things of a discharged patient who was earlier treated, has gone home, has to follow. So it is in parts, and I would like Kavalpreet, you want to start with it? You can start.
Sure, ma'am. Actually, when we decide to discharge the patient has to be symptom-free. And after 14, on 5th and 7th day, usually we take the nasopharyngeal swabs. And once we have a negative nasopharyngeal RT-PCR sampling, 2 consecutive RT-PCR tests have to be negative, 2 consecutive over 24 hours apart. So that is the time we decide, yes, we can, the patient is COVID negative, but still the patient has to be discharged, giving an advice for 14 days more. He is into the convalescent phase. That means he can still be infective. He is not symptomatic, but the infection part remains till 28 days. And the viral shedding in the reports has been supposedly said to be up to even 37 days. So it's a long viral shedding period. So we have to be very much aware of this thing.
So anything what the patient needs to do after his discharge, can he just move around, or he is immune and the other people have to take care? Anything on that? Gunjan, you want to add something on this?
I just want to add one thing is, though they say that after 2 negative RT-PCRs, the patient can be discharged, but still now they say the patient can continue discharging or whatever. The virus can still be present in the patient's feces or secretions, which is again very a controversial topic. So we really can't say when a patient is totally non-infective. I think Bharat wants to add something.
Yeah. So let Bharat also add.
Yeah.
This is very important.
Discharge is very clearly said by Kaval. You need to have 2 negative samples, that is RT-PCR, at 24 hours apart. And as Gunjan said, so infectivity as far as the fomites and airborne is concerned is almost gone. But you continue to be shedding your viruses in your feces and urine. It's been very well known till 28 days, and sometimes it's as long as 37 days. So any discharge which has happened, considering 2 RT-PCRs negative, those patients are advised strictly to be quarantined and self-isolated at their home places. And whenever they use the washroom, they have to desanitize it either with Lysol or Harpic or something Domex. And this is the kind of advice it goes to. So once you're discharged, it doesn't mean from airborne point of view, fomite point of view, obviously you're not infective. But virus shedding do happen through the urine and feces till 28 days. So that has to be taken care of. But having said that, fecal-oral route is still not been identified. So how bad that shedding in the urine and feces have to happen and how infective it is going to happen, we have no idea. But it definitely gets shed in the urine and feces till 28 days.
Okay. So what advice do we given to the patient who has gone home after discharge? So,
it's a self-isolation for 14 days, quarantine for 14 days, avoid close contact with the relatives, use your own utensils, wash your own utensils, desanitize your bathroom after every use. So whenever you're gone to urinate or pass feces, you have to put on the Lysol or the Harpic in their surroundings and report as soon as if there's any fever or something on that side.
Okay.
Perfectly, sir.
Yeah, so it is very well answered everything, because the main query is the patient coming home. So we need to keep in mind that whenever the patient is discharged, a patient still has to follow the basic hygiene and tips.
I could now we will correctly, because today we discharged one patient and I had to make the summary. So we wrote down all these points in that, and that is how I remember it very clearly.
Yes. Now I want to put all the panelists some take-home messages which you want to give to all the audience. So we can start with you, Dr. Bharat, first.
Take-home messages, as I very well said, you are very safe in the COVID area, you are unsafe in non-COVID area. So you don't, one should not worry about looking after the COVID patients with all the protections on, because if you're working in a COVID area and you're infected, it will be only because otherwise it will not happen. And practice the good methods of etiquette, hand hygiene, and maintain a safe distance from your elderly parents if you're working in a COVID area.
Fine. So that is very well said, Dr. Bharat. I would just like to add that as being intensivists, we should probably be taking care well of our staff and mainly for their emotional health. Teamwork is the key for the whole success of this pandemic. And I think for a common man, we should probably emphasize more on primary prevention than anything else. So staying home, staying safe is the best option for every human being that can help us contain the epidemic.
Should I continue?
Yeah.
Yes.
Please, Dr. Kaval can go ahead.
Yeah. Okay. Actually, as Dr. Gunjan and Dr. Bharat very nicely talked about, actually, I was going through the morning news, Dr. Panjwani from Indore, who had a demise because of this COVID. And what I could get was like he was negative previously and he kept on seeing the patients and ultimately came out to be COVID positive and he was a victim of COVID-19. So what we have to keep in mind as healthcare workers is we have to like stay safe to keep others safe, sort of. And certainly to build up the team and take the team together and take care of your healthcare workers and your colleagues. And I wish nobody goes into nobody from the teams. Otherwise, the scenario will be very bad.
I think one message I would definitely also want to convey to all the pregnant women and their families is that the families need to be also very careful. You know, they think they've kept the pregnant woman in the house and she is not exposed, but they themselves are going out and interacting and bringing home that infection which she gets. So they must be equally cautious in isolating themselves, recognizing the problems they are carrying home to their members.
Very good. Yeah, fine. So, are there any more questions now? Any specific questions? What are the precautions do we take while handling the airway in COVID patients? Dr. Bharat, what all precautions do we take while handling the airway in COVID patients? Dr. Bharat, unmute.
That has been explained by Gunjan very well, and it has been explained.
Already taken up.
Yeah, we already discussed in length with it. You want me to repeat it or?
How do we take nasopharyngeal swabs?
I think nasopharyngeal swabs needs to be taken. Microbiologist needs to answer it, but what has been shown is it has to go deep inside and it has to remain there at least for the 10 seconds for the test being positive. So if you
Yes, please. Hello, Dr. Bharat?
Yeah.
Yeah. Okay. So are there any more questions? Okay. Well, we have most of the questions have been asked. Any specific ventilation strategies, Dr. Kamaljeet Sodhi?
Ventilation strategies, basically, the initial guidelines said that we have to go as per the ARDS ventilation. But certainly, now what has been proved in the latest studies is that it should be a non-protective ventilation, but high PEEPs are not recommended. We have to give a tidal volume of around 6 mils per kg body weight and going by a PEEP of around 10. That is what usually suffices for most of the patients. And certainly limiting the PEEP plaques will be a factor as of other ARDS patients, but patients should be nicely sedated and even the use of neuromuscular blockers has been recommended for and early proning. That is what is recommended. Even people are doing the awake proning. In awake patients, they are proning the patients for 16 to 18 or 20 hours per day. And this early proning has been proven to be very useful for many patients.
Okay, I think we will end this session now, and all of you have answered very nicely. I would like to thank each one of you, Dr. Gunjan, Dr. Bharat, Dr. Kamalpreet Sodhi, Dr. Nirja Batla Madam, Dr. Aparna Sharma and Dr. Rajesh Kumari, that we have given justice to this program, and we had a good number of our viewers to be there, and thank you all of you. We will come back to you soon. And it was a pleasure to have you all on our show today. I would like to thank Dr. Komal Chavan, She has also done a wonderful job with me, and I wish that we get less and less COVID patients in future, and less patients go on ventilators, and India improves its score. And the most important thing is that the lockdown gets over on 14th of April, and everyone goes back to life. Hopefully, everything should subside. Sometime when I wake up in the morning and I go to my hospital, I feel whether I'm in a dream, is this a reality? But unfortunately, it is a reality that today whole of India is locked down, and we are all still, as a health care providers and workers, we are still going to our hospitals and doing our best and giving our best. See that all of you be safe, stay safe, keep yourself safe. Nirja Batla madam and your team and the medical intensivists were wonderful. We will catch up with you soon. Thank you so much. I would like to end this program with a wonderful video. Please be online, and our viewers to be online and see this video. Thank you so much. Bye.
Thank you for having us, sir.
Thank you, sir. Thank you, sir.
Thank you.